Good evening, everyone, and thank you for joining PCHF's webinar series. My name is Dr. Samaa Akhtar, and I am honored to extend a very warm welcome to Associate Professor Dr. Babar Hasan. Dr. Hasan is an AKU and Harvard alumnus and diplomat, American Board of Pediatrics and Pediatric Cardiology. He is currently a consultant pediatric cardiologist at AKUH and Service Line Chief, Children's Hospital Service Line, the Al Khan University. Apart from being an extraordinary pediatric cardiologist, Dr. Hasan is an exemplary mentor and teacher. He is the recipient of the Dragon Special Endorsement Award, the Andrew Jones Memorial Resident Teaching Award, the Red Shoe Award, among others. He has developed several national pediatric cardiology and adult cardiology heart programs and is a member of 10 professional societies and committees. An ardent advocate of quality healthcare regardless of resource settings, Dr. Hasan initiated the IQIC, thereby benchmarking the congenital heart disease program with 50 developing countries. He has also helped develop the structured clinical assessment and management protocol in conjunction with Boston Children's Hospital. As a commendable researcher with an extensive list and array of publications, Dr. Hasan has recently acquired a $2.5 million grant from the Bill and Melinda Gates Foundation. Today, he will be talking about the use of technology and artificial intelligence in low-resource CHD care. Welcome, Dr. Hasan, and over to you.
Thank you very much, Samaa, and thank you to the PCHF leadership for inviting me, giving me this opportunity. Just a couple of things that I'll just clear. I'm the ex-service line chief, and also the IQIC CATH registry is what I developed, and the Gates Foundation grant is an equal partnership collaborative grant, and some of the team members that got it along with us is somebody that we'll show in the presentation. So thank you very much for this opportunity. So what I'm going to be talking about over the next half an hour is basically use of technology to improve healthcare delivery in low resource environment. And it's kind of, sounds like a broad topic, but I will be focusing on some of the congenital and rheumatic heart disease problems that we are facing and how one can use technology or AI to solve some of these issues. So if one was to look at what is our problem in our part of the world, the biggest issue is the burden of disease, and it's predominantly related to the population, the amount of people that live in our part of the world. The lack of resources to take care of some of those illnesses. And one of the biggest thing about resource is the healthcare workforce. And what this kind of map shows is that there is a significant dearth of healthcare workers in countries that are the most populous. And so that disparity in itself leads to the healthcare outcomes, or the differences in healthcare outcomes and outreach in our part of the world. So if one was to think about healthcare delivery, tackling burden of disease is one aspect, which basically is kind of associated with population control. But the other aspect is healthcare delivery in a more efficient manner, and how can one use technology and AI to really kind of bridge that gap between the dearth of healthcare workers and the burden of disease. So if one was to look at the sustainable developmental goal, what it does is that it kind of takes away the focus, or not takes away, but at least highlights some of the issues that are present in a middle income country like Pakistan. So we are not only burdened by the diseases or the communicable diseases that one sees in the developing world or the low middle income countries, like polio and diarrhea and pneumonia. But at the same time, we have an equal burden of non-communicable diseases, for example, coronary artery disease, ischemic heart disease, and congenital heart disease. So just to give you a perspective, 4 countries in the world contribute to nearly 50% of congenital heart disease volume that one sees globally. So those 4 countries are Pakistan, India, China, and Indonesia. It's purely based on the number of births happening. So 9 out of 1,000 kids will have congenital heart disease. So the more the babies are being born in a country, the more burden of congenital heart disease one will see. Rheumatic heart disease, which is a disease that happens after one contracts throat infections. Pakistan has the third largest burden globally of rheumatic heart disease. So not only are we kind of struggling to deal with communicable diseases of low middle income country, we are also struggling to deal with these chronic non-communicable diseases, which unfortunately requires a different kind of skill set and a different kind of mentality. Communicable diseases is more of a public health access issue, but when it comes to healthcare delivery, it is not, it's kind of simplistic. It does not require a lot of skill sets on the person delivering that kind of healthcare. It's more of a public health skill set rather than a healthcare skill set. But when it comes to non-communicable diseases, what one requires is a very specialized kind of skill set to deliver quality care. And access without quality is actually more harmful than beneficial. So how do we deal with the whole goals of sustainable developmental goals, and how do we really achieve those is something that we need to start thinking, because 2030 is literally around the corner. And how would we transform some of that to achieve some of these goals? So, these are a couple of things that, I want to kind of also share, is that Pakistan has one of the highest neonatal mortality among the countries in the world, also has a pretty high maternal mortality. And this also, yes, pertains to a lot of the antenatal issues, intrapartum issues, but is also something that is linked to a higher prevalence of congenital heart disease and non-communicable diseases. And if you want to see that the majority of the mortality happens in the first 7 days of life, in fact, in the first 2 to 3 days of life is when the mortality happens in the neonates. So some of the projects that I'll show you going forward are kind of looking at a problem not just from the lens of congenital heart disease, but from the lens of we being in a country that has a double burden of disease. And at the same time, also from the lens of where is the problem and how do we contextually solve it. And so the solutions that I'm going to show you down the line and during the presentation are mainly kind of focused on what we call the task sharing model, in which how can we use the low-skilled healthcare worker and kind of transform them or augment their skill set by using artificial intelligence and technology, but not just to solve a small siloed disease, but actually looking at that in a much broader manner. And what do I mean by that? Some of that you will see as I go forward in the presentation. So Pakistan has one of the worst infant mortality rate in the world. This was one of the UNICEF reports, nothing to be proud of. And then along with that, as I mentioned, a significant burden of congenital heart disease and rheumatic heart disease. So this is an amazing document that I would encourage people to read. It is about how does one think about artificial intelligence and technology in a developing country perspective. And what it basically talks about is that it has to be contextually relevant. It has to be something that evolves from within. And then it has to have the mentality of what I call social innovation, in which it basically means that it has to have the ability of having scalability. So once one starts thinking of technology or AI from those different perspectives, is when one starts thinking of really bringing all the stakeholders in the room, and also not to just create yet another algorithm or yet another technology tool, but to contextualize it according to where the problem lies. So as I mentioned, key principles were complement best practices, strengthen local health systems, and then owned and driven by needs of low middle income country. So these are the 4 places that they kind of mentioned that technology or AI can, in broad categories, facilitate healthcare delivery in our part of the world and within our context of a huge burden and low resources. So an AI-enabled population health, for example, AI or patient virtual health assistant, a frontline health worker virtual health assistant, and a physician decision support tool. So some of those examples, for example, this is they give in this document only, is that tracking, a classic example in COVID, tracking the COVID outbreaks, tracking how COVID is spreading using AI is something that one can employ in population health and deliver healthcare through that. Frontline health worker assistant can be something like a tool. For example, this is an example in which they gave of a frontline health worker diagnosing a rash using a phone-based app. But some of the examples that I'll go later on is also tools to facilitate the frontline health worker, like our lady health worker or community health worker, and augment their skills using some of this technology. And similarly, they give all these different examples in all of these different categories of healthcare and decision support for physicians and stuff. So again, as I mentioned, the ideology behind our work has been from the lens of task sharing, and how do we get lesser trained healthcare providers and augment their skills so that using AI, so that the highly skilled health individuals are not overburdened and overused, and they're used for the right skill sets. But at the same time, also to detect early, to treat early, and to refer early whenever it's needed. We always hear about challenges in our part of the world. We hear about high burden, low resources, high mortality, but there's also big opportunities that if one starts looking at innovation, gives our part of the world a distinct advantage over many. So this is, just a report that came out of the World Development Report. And what they basically showed, World Bank, was that, there's a huge number of people in our part of the world who have access to phones and also to internet. And there is an exponential growth to the access to 3G, 4G technology, and eventually 5G technology. And that growth is exponential in low middle income regions. In fact, this report mentions that there are households where you won't have drinking water, but you'll have a smartphone in that person's hand. So how does one use that, this kind of a quote unquote advantage, or this kind of a demographics to our advantage to solve our contextual problem? So this is our first project. This was something funded by the Bill and Melinda Gates Foundation. And this was the PI on this project is Dr. Zara Hudboy and our team. This team consisted of multiple people. Dr. Devyani Chaudhary from Pennsylvania, who works very closely with the Amish population. Dr. Bart Bennon, who is our engineer, our AI expert from Barcelona. And then some conventional statistical modeling that was done at Boston Children's Hospital. So the whole idea behind this was, again, to target neonatal or mortality, which happens within the first 24 hours, but in a predictive manner. So the idea was that, is there a way by which we can track the journey of this mother during pregnancy and start predicting the outcome of the child at birth, and then and once one can predict, at least start labeling a high risk pregnancy versus a low risk, and then eventually delegating resources accordingly. So this study was done in a remote part of a suburban fishery village here in Karachi, so that it is kind of the context stays true to what we are dealing with. And these are some of the pictures. This is just one of the sites. I'm going to show you the video so that you guys can have can you see the video? Is it playing? Yeah, so just so that you can get a context that these technologies and these things are not kind of done in isolation. It is literally going there, feeling, understanding what the problem is, and then trying to solve it. So this was the study flow. We kind of enrolled patients during their pregnancy, and then we did some fetal echocardiograms or fetal Dopplers, not echo, but Doppler scans during the 22 to 26 week period, and then 30 to 34 weeks period. And the whole idea was to use the Doppler, the shape of the Dopplers to start coming up with an algorithm to predict outcomes. So this is one of our sonographers actually who's sitting in the community taking the whole Doppler scans. This is within the community, doing Dopplers on pregnant women and getting all these scans done. And then we basically did some fetal biometry. We broke down the whole wave into different waveforms and different points, and we ingested the whole shape of the wave into the algorithms. And the study outcome was to basically predict, primary outcome was to predict stillbirths and early neonatal mortality. And the secondary outcomes was to look at prematurity, low birth weight, birth asphyxia, and early neonatal sepsis. So again, kind of targeting not just a problem in a silo, but as a big issue, because in this whole group of patients, naturally, congenital heart disease will also fall within this group of patients, the critical congenital heart disease patients who will have early mortality as a neonate. So we did around 866 scans. These are the different breakups of it. We had 25 stillbirths, 19 neonatal, early neonatal mortality, 117 growth restriction babies. And again, we basically looked at the shape of the waveforms from all the Dopplers, and we used some conventional machine learning techniques. This is one of our conventional machine learning techniques to create prediction models. And then we also used something known as the Shapley technique, in which we basically identified which were the Dopplers or which were the factors that were driving the prediction. And this is an interesting curve that basically looks at, so we basically gave these scans to 5 different experts and calculated sensitivity and specificity compared to their prediction and what our algorithm was doing. And our algorithm was outperforming a majority of these experts in predicting neonates or fetuses that had a higher risk of either being stillbirth or early neonatal mortality. And even for the for gestational age patients, we were able to predict better. We also used, in fact, this is the more powerful technique that we are using, and it's basically known as the multi-kernel learning technique, in which we project all the features into a space and then start clustering the patients into different clusters and looking at similarity of these clusters. We basically are able to identify patients who are in a low risk cluster versus a high risk cluster, or who will move from a high risk or low risk into a high risk over time, or vice versa. So using these techniques, what is also interesting is that you can also go back and really map these waves and figure out what is the pathophysiology behind a patient being high risk, and it can be very individualistically driven. So we are, naturally getting 9 Dopplers or 10 Dopplers in the community is not an easy thing to do. So we have actually now created a similar model, which we call the low-tech approach, using only 4 Dopplers, which are very easily obtainable. In fact, we just recently are rolling out our second phase, which just recently got funded by the Gates Foundation. That's the 2.5 million that Samaa mentioned, for our validation phase, in which we are teaching some of the downstream health staff to acquire these images, and we've been decently successful in teaching them this. So our next project, which is funded by the Islamic Development Bank, is on the pulse oximeter. So all of us are familiar with this device. Basically looks at what is the oxygen level in a baby or an adult. And what is interesting is that majority of the times the pulse oximeter number is what people will use for decision making. But there is a lot of information within the waveform of a pulse oximeter. And this is just to give you an example. You can see a distinct difference in how the waveform looks in a patient with congenital heart disease versus sepsis versus being preemie or versus a well baby. So if one was to use these waveforms and put them into an MKL model and basically design clusters, is there a way by which just using a simple pulse waveform, we can predict which baby has sepsis, which neonate has congenital heart disease, and which baby is actually doing well? One can easily triage appropriately and have an early appropriate referral. So this is how we are doing it. We are basically we've been lucky to work with a company who has given us all the access to the data form. We extract all of the waveforms and then we project them into different spaces. And looking at the different waveforms and different spaces, one can identify which patient, and these spaces can distinguish between a well baby versus a sick baby, and then within the sick, whether somebody has congenital heart disease or sepsis. This is still a work in progress, but pretty promising at this stage. So this is the next thing that from a device standpoint, this is known as the butterfly device. I think I always say this to my students and stuff that, murmurs and sounds that we hear through our stethoscope, is definitely pretty worthwhile. But I think technology is going to take over all of that. This is a person in Africa who's using a butterfly device that connects to the phone to do ultrasound on the lungs, to do ultrasound on the belly. And this device is also being used. In fact, one of the things in our Gates Foundation grant is to actually work with this device and see if we can start acquiring images, Doppler images, and using machine learning techniques, direct the person or the user to acquire these images. Similarly, using a similar kind of an approach, this device, we are working with a couple of groups to see if, based on just few images of the heart on a neonate, directed by the device, and being used by a low-skilled person who's not trained in doing echoes or ultrasound, can we acquire images and then using convolution neural networks predict which image is that of a child with heart disease versus not, and then do referral accordingly. The next problem, as I mentioned, was the rheumatic heart disease. And traditionally, rheumatic heart disease, the most effective way of dealing with rheumatic heart disease is secondary prophylaxis. So basically, somebody who has already gotten the infection, some involvement of the heart, and preventing them from getting repeated insults to the heart by giving them penicillins. So, but how does the challenge that comes in that whole thing is that how does one pick those children between the age of 5 to 15 who have had an episode of rheumatic fever and have had some involvement of their heart, but it is not significant enough to cause enough noise for one to listen to it and hear it on a regular stethoscope, or for that patient to have symptoms. So basically what we call indolent carditis or asymptomatic carditis. But what is interesting is that if you look at how cardiologists in the 40s and the 50s diagnosed cardiac diseases, and they used to use phonocardiograms or augmented heart sounds to basically diagnose cardiac diseases. So we've used a similar concept. It's been funded by one of our University Research Council grants, and we are using a digital stethoscope to record these sounds and then use machine learning techniques to cluster these signals and see if we can identify indolent carditis. So the whole idea being that you can imagine that you can have a digital stethoscope, which is pretty cheap, around $100 to $150, given to a school nurse who is using this device or putting the device on school children. The device picks the sound. It basically Bluetooths it to your phone. The phone then uses Wi-Fi and puts those signals onto a neural network. and the neural network within 15 seconds or so basically spews out whether these signals are consistent with somebody with indolent carditis versus not. And then those who are found to have signals consistent with indolent carditis are then referred for further screening. So one can imagine the power of this technology in catching rheumatic heart disease early on and then treating it. So this is another interesting technology that we have used in our ICU. This is known as ethiometry and T3. T3 means tracking trajectory and triggering. So this device or this technology basically is something that was made by a company in Boston. And what they do is that they ingest data, high volume and high velocity data from the bedside of a cardiac ICU post-operative patient. And basically all the monitor data, infusion pumps, ventilators, and it puts it into a closed physics model and predicts the tissue oxygen delivery. And this line that you see up here is basically how it displays it. So once your line starts getting red, it basically means that the tissue oxygen delivery is getting compromised. And what it does is that it can trigger the healthcare provider at the bedside to then start taking actions, because as you start taking actions, every 15 seconds, this line kind of gets updated. You can see the response. If it starts getting green, that means you are, the patient is responding to what you're doing. If one was to leave this patient with this red line for 6 hours, the prediction of them getting into some kind of an adverse event like a cardiopulmonary arrest is close to 0.85 to 0.87 AOC. So we did a similar thing in our setting. We actually did a prediction of a mixed venous saturation using ethiometry. And mixed venous saturation is an indicator of poor tissue oxygen delivery. And what we found was that the ethiometry had a very high AOC of 0.87 in predicting poor mixed venous saturations in even our population at the Aga Khan University. So contextualizing it. But again, if just to kind of give a perspective of what it means is that, you have somebody, a complex child being operated and comes out into the cardiac ICU, and the bedside nurse who's not probably that much trained in dealing with a complex congenital heart disease patient. Now their skill is augmented using this tool. And the only thing literally they have to do is to trigger the system, get the intensivist, get the cardiologist, get the surgeon in. If the line is persistently up and into the red zone and the patient is not responding, i.e. that the line is not becoming green, they will respond and trigger. And the whole idea is that by intervening early, hopefully we will prevent an adverse event in these patients. This is another project that we are working on. This is in patients with Thalassemia Major. They have iron deposition in their heart. And the way one predicts iron deposition in the heart is by using cardiac MRI. The problem that we were facing is that the software used to detect or to read these studies is pretty expensive. The second thing is that such MRIs are only available in very few centers in Pakistan. So how does one, really bring it to the masses or give access to the masses? And so this is what we basically did was that we have used different images and segmentation techniques and using a predictive model without the help of a software able to predict how much the iron load of the heart is, but then tie this in with this very cool device. And this is a portable MRI machine, Hyperfine. And just to kind of show you this, look at this. It basically runs out of it works out of a car battery. So a portable device that it doesn't show, but a portable device that works out of a car battery, and you can easily basically pick these images from any community, run them over a neural network, and let those physicians know how much the iron load is. This is also a work in progress. Will take some time to kind of mature into the way we want it to get matured. The point I want to make is that any such fancy thing that you want to do, it has to be done in the context. So I'm just going to show you this picture here. This is Dr. Bart Benin, who is our engineer from Barcelona. This is Dr. Divyani Chaudhary. This is Dr. Anita Zaidi. This is all of our team standing in Reddy Goat and Ibrahim Hedri and kind of really ingesting the context, because only then the solutions are scalable, the solutions are contextual. And it's extremely important to really have that perspective and not just do things in silos and yet again produce another algorithm or yet another paper that does not have any meaning or impact downstream. And as they say, it takes a village to raise a child. It takes a group, a huge group, to really create such work. Similarly, we have a similar kind of a huge group that works in cohesion with each other. We basically, and the whole idea, the whole objective, the vision is the future of any child with heart disease should not be determined by imaginary lines on the globe. Thank you very much.
Thank you very much, Dr. Hasan, for a spectacular presentation, which was very informative. And apologies and thank you for the clarification in the beginning of the presentation. So we will be moving on to question and answers shortly. Before we start, sir, I have a question for you. In terms of application of artificial intelligence in middle-income countries, what does it mean for the skill requirements of health professionals? Because as far as I am aware, it is not mainstream in terms of health education in Pakistan to train our future physicians and our future health professionals in artificial intelligence.
Great question, Sama, and I'll answer it with in a couple of ways. The very first skill that you need whenever you are doing such work is humility. And we physicians at times we lack that factor. So the one thing that we need to teach our medical students or the future doctors is humility. Don't think that knowledge only lies with us. And I think once one determines that or understands that is when one then starts developing a team like this and start working with each other's expertise and start understanding that everybody brings something to the table. Irrespective of how many courses I do in AI or machine learning, will never be as good as my engineers. This is what they've been doing, living, breathing for the past several years. Similarly, irrespective of how much AI, ML they do, in the end, getting those images, training the technician to get those, all of those, it's not even their domain. They can't even do it. So they can't do it without us, kind of a thing. Similarly, if the technician is not going to the community, putting in that effort of getting these pristine data, none of us can function. So I think it's that humility that has to be taught as a skill set, to understand that healthcare delivery is not going to be something that is a domain of a physician. That has always been the case, that we've thought that healthcare delivery is the domain of a physician or a surgeon, and that no longer is true. When it comes to other skill sets, I think it's important also, and many medical schools in the US are now moving towards that, is to really teach the idea of data science to our physicians, and because that's how the world is going to evolve, and data science and technology should be a part of their skill sets, and rather than being technology aversive, which is the easiest thing to do, I think we need to adopt technology. We need to adopt these newer things and not be scared of it. I think the technology, and especially AI, has been really disruptive in that manner that it in some way and form may help us get rid of the disparity in healthcare delivery around the world.
Absolutely. Thank you for that. Moving on to the next question. When you mentioned the task sharing model, you mentioned scalability and engaging stakeholders. Could you please elaborate on how institutions in Pakistan, particularly with congenital heart disease related congenital disease related models could proceed or approach that scalability?
Absolutely. I think that's a great question again. So by stakeholders, I mean, and I'll give you an example. So if you look at the one of the slides that I showed you, in which I showed how many users are around the world using using cell phones, using internet. One of your biggest stakeholder can be the connectivity industry and the communication industry, and and this is something one can they can you can liaison with them, and whichever work that you're doing, the scalability of it will come with that kind of a collaborative approach to healthcare. I think the biggest thing that it comes before any of this comes, any of this collaboration or anything comes, is to really first of all own the problem. uh, ये हमारी दुनिया है, this is our world, और ये हमारी जिम्मेदारी है, सही है, and this is our responsibility. Nobody is going to come and fix our backyard, सही है. The external stakeholders have their own and their own objectives, their own outcomes, and for them we will always stay a country of diarrhea, pneumonia, and tuberculosis and polio, unfortunately. And I think our backyard reality is, yes, that too, but also a huge amount of other things too. And I think once we start owning our backyard is when we will start coming up with solutions to it. We don't have to go that far to really see what I mean by when I say this. You just have to look at our next door neighbor and see how they have approached their complex diseases. There are centers in India which are doing twice the number of congenital heart disease surgeries compared to one of the top centers in the West. And I think and not only just doing the surgeries, but with outcomes that are comparable. And I think that's where we have to really develop that self-esteem, and own our backyard. Once we start owning our backyards, collaborations will evolve. अभी तो सारा वक्त we are kind of in a competitive mode. I don't want to work with that person because that person is my competitor. In the end, what if we all think about it as an approach towards solving problem in our backyard, so that a child sitting in remote Sindh or remote Punjab or remote Balochistan or remote KPK should not die or should not have a future that is determined by imaginary lines on the globe. I think that's when we start solving problems and reaching out and creating collaborations. And then all these stakeholders will fall in place.
Right, sir. So again, elaborating a bit more on the stakeholder aspect of artificial intelligence, what will this mean in terms of cost in accessing healthcare? Will this result in an inflation, or if you could please elaborate on that aspect?
Yeah, so main cheese, Dr. Sama, is that, again, just to take the example of congenital heart disease and look at the patient journey, for example, if you look at the buckets of problems where we see majority of our issues kind of lie, the bucket of having a high burden of disease, the bucket of having late recognition and thus late referral, which then leads to a late presenting kid with comorbidities, the bucket of having centers that are limited, that can provide high quality care, and the bucket of actually defining quality, because currently the way we define our healthcare outcomes is कि कितनी surgeries हो गई, how many surgeries we have done, we have done 800 surgeries. Well, what is the outcome of that? Nobody knows. So that outcome framework has not been developed, and thanks to the Lancet Commission, that report kind of highlights this, that quality in healthcare is not a privilege, it's actually a right. In fact, poor quality care and access without quality actually leads to more harm and more cost of care. So once one starts thinking of these buckets is when the problems and the issues and the solutions come in place. So upfront, you may find it a little bit costly to deploy a system, for example, like ethiometry. So yeah, it may be an upfront cost in deploying it in your cardiac ICU, but downstream, if it is decreasing the length of stay to your patients, if it is decreasing the mortality, if it is decreasing any adverse events in those patients, and it basically is making them go through their post-operative course uneventfully and much quicker, without complications, you actually in the long run are saving far more money, far more money than what you invested up front. So I think mentality, it's all about the mentality. We unfortunately are a nation that live from one day to another. And so for us is that those short-term outcomes, and we don't look at a long-term investment. And I think that mentality has to change in some way or form. Then these projects or these things may not look expensive upfront. They actually may look extremely cost effective when you take the whole context and picture.
It's interesting you mentioned outcome framework. Okay, my next question यही था कि what would be your predictions on the use of AI in improving health outcomes? So I think that answers it. कि सबसे पहले the first step is to actually formulate an outcome framework in order to engage stakeholders more in this step.
Absolutely,
Sir,
but Samaa, I'll just mention one thing here is that the first step actually is to really not accept the number of surgeries done as an outcome. That is the first and the foremost. We have to not just accept the number of surgeries done as an outcome. The outcome has to be, what's the mortality, what's the morbidity, how is the patient's health over a life cycle of health, and then this whole predictive analytics will basically play that role into. But if you are just focused on how many surgeries we have done, then none of this technology is going to help you. So I think that is important to really have that conversation at a national level, that outcome, that definition of an outcome, a definition of a metric, and tracking and benchmarking of things, I think will be the first step, and followed by using predictive analytics to then predict outcomes and metric.
Before winding up, sir, unfortunately we are running short on time. There is one last question that I would like to ask you. आपने mention किया था about mentality and stigmas as one of the challenges of implementation of artificial intelligence. I was reading one of your papers titled "Does Artificial Intelligence have any role in healthcare in low resource settings?" So Iskandar, you and your team conducted an online survey of responses. Could you please elaborate on this study के उसके significant outcomes क्या थे?
So the main thing that we basically showed in that whole thing was kind of what's the knowledge that people have about AI, their acceptance to it, and then what are the different barriers that people thought were there for them to kind of implement AI, And I think the biggest thing which was encouraging to see was majority thought that AI is the future, and AI is the future in not just healthcare, but many of the other walks of life. And not a distant future, but in fact, very much. In fact, it's becoming more and more the present than the future. The second thing which was interesting that came out is that majority showed interest in doing it. Whether it was healthcare, whether it was physicians, engineers, majority showed a lot of interest in learning it and employing AI solutions. And the barriers that people identified again was skill sets and funding. And again, I think वही है कि, everything, majority of the work that I've shown you has been done with local skills, and also mentored by Dr. Bart Bennen in Barcelona. But it's completely doable. And the funding basically will come when we start owning our backyard. So this is all doable. This is not something that requires a lot of effort.
ठीक हो गया. Thank you, sir. Questions तो definitely बहुत सारे हैं, but unfortunately we have limited time. So before we wind up, sir, if you could have some concluding comments, and may I please request you, if you could please remove your slides so that our viewers, our participants can see Dr. Babar Hasan.
Okay, I will remove the slides. Okay, so the concluding remarks are basically that UNESCO is, we were doing a camp for congenital heart disease in one of the communities, and वहाँ पे एक class grade 5, a student of grade 5 basically had a very interesting painting, and it basically said हमारी दुनिया हमारी जिम्मेदारी, our world, our responsibility. And I take it, and I think that's my concluding message, and think कि भाई, we have to own our backyard. जब तक हम अपने backyard को own नहीं करेंगे, our patients, our families, our loved ones are going to have a very different outcome, and which will be determined by the imaginary line on the globe. हमें थोड़ी सी अपनी self esteem पैदा करनी है. If our neighbor can do it, we can do it. हम एक ICC का Champions Trophy जीत के तो सड़कों पे निकल आते हैं, पर एक valve नहीं बना पाए हैं अब तक, So I think we just have to really get out of this mentality that the external funders have imparted on us. We are just a nation of communicable diseases, and we have to really start owning the backyard and contextually, collaboratively work towards this. And so that will be my concluding remark and message.
Thank you very much, Dr. Babar Hasan. Definitely, I think within our country itself, mentors such as yourself, we have so many resources. It's just about coming together as a community and then just applying whatever we have, like you mentioned, in our backyard. I believe Mr. Farhan would like to join us and give some concluding words. He has joined. Welcome, Sir Farhan.
Assalamualaikum, Farhan.
Assalamualaikum, Babar. How are you, sir?
ठीक ठाक, अल्लाह का शुक्र.
बहुत बहुत शुक्रिया बाबर आपका. जज़ाकल्लाह खैर. It's always an honor कि आप जैसे लोग जो हैं वो इस cause में हमारे साथ हैं. And सब viewers को अस्सलाम वालेकुम. समा आपको भी अस्सलाम वालेकुम. Babar is one of those individuals जिसने माशाल्लाह PCHF को हर platform पर बहुत support किया है. And we are always thrilled and excited कि the way माशाल्लाह Dr. Babar का जो vision है exactly same हमारा vision भी aligned है in terms of supporting the congenital heart disease community internationally, globally. So ज़्यादा words तो नहीं है Babar, but I really would like to thank you especially for all you have done. And we hope that together, inshallah, there's a long way to go, but still I think जिन lines पर हम काम कर रहे हैं, inshallah बहुत जल्दी बहुत कुछ इकट्ठे करेंगे, sir.
Absolutely, Farhan. Bilkul. It's what we have to understand. This is a marathon. This is a collaborative effort, and there is no competition. This is all meant for the child downstream. That's what our goal should be.
Definitely, and for Pakistan, of course. So thank you to Dr. Babar Hasan, Mr. Farhan Ahmed, to our panelists, to our guests, and to everyone. And we hope to see you again in our next webinar. Thank you, and Allah Hafiz.
Allah Hafiz.